what Kiddo Health does. Kiddo Health is a care coordination platform that focuses on pediatric chronic disease support and education. We primarily focus on two large care pathways. So kids with acute behavioral health issues, so kids with anxiety, depression, and autism spectrum disorders. We also cater to kids with metabolic syndrome issues, so kids with obesity, type 1 and type 2 diabetes. Most of our focus is on kids between 5 to 15 years of age. We're a pure B2B2C platform. We have a 4-layer product stack. So the first part is really a mobile application that parents and caregivers use to really understand the daily health profile of the kid. A lot of vitals actually accrue into this mobile application. There's a journaling function that allows the parent to really kind of note what's happening with respect to the kid. And then there's patient navigation and scheduling bundled in with that. We also have a FDA Class 2 device that the child actually wears. Parent, what do they want to kind of see? What are the motivations for the provider? And we kind of sit in between both of those parties and just make sure that everyone has the right trend, they have the right kind of insight, they have the right knowledge to be able to kind of take the decision that is best for that particular kid. So on the parent side, we're looking at, are we actually reducing overall exacerbations for the kid? Because that's really the outcome that the parent really wants, that the kid needs to become healthier. The second piece is obviously just qualitatively, does the parent believe that they are more informed, better informed, and better able to deal with their provider and that condition of the kid, just from an education level kind of perspective? What is the feeling that the parent has? And the last but not the least, there are additional elements around kind of things like missed school days. How do you reduce number of kind of missed school days for the child? And that comes back to the amount of time that the parent is actually spending with respect to the kid, from an ancillary kind of perspective. How do you effectively kind of reduce that?
What we set out to do was transform or set a new direction by combining digital assets and human touch. Really going past legacy pain points like things are either a service or a product, or things are scalable or personalized. That if you really want to reach and influence teens, which I don't need to tell you, has been a problem throughout, way before this generation, we've got to give them what they like and what they need. And so what we did was we built a comprehensive platform that allows things like content and care activities, which I'm calling a new category, or I'd like to say category queen. Struggle with diabetes, you could have a clinical diagnosis, you could be at risk for a clinical diagnosis. You don't need my app to tell you that teens are stressed. 100% hit the perceived stress scale that they're stressed. We need to help them manage better. We need to equip and empower them with a sense of agency. And in order to do that, we had to put a tiered level of support or a sequence of interventions across the continuum. So there's two ways that we look at value. One is engagement with this population, right? And the second is impact. So when we think about engagement, mental health as an industry used to be about time saved, right? All these great long inpatient days start shrinking and shrinking. And I think people like social media have been focused on time spent, right? And it led to addiction. And so what we're thinking about as we think about it more in the time spectrum is time well invested. So instead of engagement, what does meaningful engagement look like with this population? And so one of our paths to defensibility is the algorithm we've built behind what we're doing so that we can have a sense of a Be Well score that transcends how we've looked at it. So it's personalized and it's feeding the teen what they need, equipping them with bite-sized skills that then lead to impact.
Our mission has been to make sure that all kids can get access to great healthcare. And our role in pediatric transformation has been trying to really solve that access gap by going to where kids are, which is, as Dr. Kraft said, in schools. And so essentially, the way that our model works is that we partner with school districts across the country to essentially turn schools into places where we can deliver virtual care. With on the one end, there's the school side, and on the other end, there's a Hazel provider, both physical health and mental health provider, fantastic clinicians, incredibly diverse. More than half of our providers identify as people of color, more than 30% speak a second language fluently. And we're essentially bringing those two things together where the kids spend the majority of their week. And there's a separate piece for us, which is the actual qualitative feedback from our families and from our students. And like with our parents, some of the kind of initial points that are just getting feedback from them on something that's been as simple as like, did we help you not have to miss work because we were able to solve something that you might have normally had to take work off of to attend? And we're hoping to get more and more into, are we giving you and your child the kind of care that's helping you better know how to support your child? You're seeing the kinds of behaviors at home that you feel better about, but also feel like you've got an actual partner in the healthcare system that you may not have had before.
We did that with the first and only actually FDA authorized diagnostic for autism for children 18 to 72 months old. And that does allow for remote assessments. And I think that that's really important. One of the things that was really frustrating, but also motivating for me as a clinician is when I'm seeing families drive, 150 miles and having to wait 13 months to come and see me as a specialist. That's unacceptable. That should never happen in the United States. We wouldn't allow that for a kid with cancer. So why are we doing that for kids with mental health issues or developmental disorders? And so figuring out how do we use technology to address those gaps, we're very proud to say that our negative predictive value is 96% and our positive predictive value is 88%. That was published, the original study in Nature Digital Medicine, and then subsequently in Intelligence-Based Medicine, an algorithmic update, which is the beauty of all of this data-informed work that we're doing, I think, collectively as a group, right? The more data and understanding you have of children and the more you help them, the more the data actually feeds back information to you so that you can measure things. Looking at equity, I think this is, again, something that is talked about a lot, but it's important to actually, show your commitment and put your money where your mouth is and actually publish on it. So we looked at covariate analysis and we recruited within our sample set of a population that mirrored the US population, that included an indigenous population, that included Hispanic, Black, low socioeconomic status. And I'm very proud that in the original study, we actually recruited a lower socioeconomic status than the average within the population.